again, thank you. There is some overlap, of course, between the presentations, but I think this is going to be helpful to highlight what is in common in these scenarios and what is different. In this case, we're focusing on ACS, which in most patients is treated by PCI, but not necessarily, and non-valvular atrial fibrillation and old patients. So we have two guidelines, the guidelines on STEMI from the ESC from 2012, and these guidelines are quite detailed and provide you guidance on the way to best approach patients who require oral anticoagulants, suggesting that in the pre-worst area you could consider triple therapy if the bleeding risk was not prohibitive, a class 1 indication. More importantly, we now have very recent guidelines on non-STEMI and unstable angina, which in part can be applied, I think, also to patients with STEMI. In this case, we have a 2B indication to rivaroxaban stemming from the ATLAS trial in favor of rivaroxaban low dose on top of aspirin and clopidogrel, and we have also clear-cut recommendation on how to minimize bleeding in patients with oral anticoagulants and whether to continue, for instance, anticoagulants in the peri-procedural phase, and which kind of regimen to give afterwards as well. We have also a very nice algorithm suggesting that if you have a patient who is admitted, if he undergoes CABG, then he can be treated with typically dual therapy, so oral anticoagulants and clopidogrel or aspirin. And this is left to your decision. Probably I would favor, in this case, aspirin, but this is not evidence. Again, thank you. There is some overlap, of course, between the presentations, but I think this is going to be helpful to highlight what is in common in these scenarios and what is different. In this case, we're focusing on ACS, which in most patients is treated by PCI, but not necessarily, and non-valvular atrial fibrillation and old patients. So we have two guidelines, the guidelines on STEMI from the ESC from 2012, and these guidelines are quite detailed and provide you guidance on the way to best approach patients who require oral anticoagulants, suggesting that in the pre-worst area you could consider triple therapy if the bleeding risk was not prohibitive, a class 1 indication. More importantly, we now have very recent guidelines on non-STEMI and unstable angina, which in part can be applied, I think, also to patients with STEMI. In this case, we have a 2B indication to rivaroxaban stemming from the ATLAS trial in favor of rivaroxaban low dose on top of aspirin and clopidogrel, and we have also clear-cut recommendation on how to minimize bleeding in patients with oral anticoagulants and whether to continue, for instance, anticoagulants in the peri-procedural phase, and which kind of regimen to give afterwards as well. We have also a very nice algorithm suggesting that if you have a patient who is admitted, if he undergoes CABG, then he can be treated with typically dual therapy, so oral anticoagulants and clopidogrel or aspirin. And this is left to your decision. Probably I would favor, in this case, aspirin, but this is not evidence-based, just opinion-based. If the patient undergoes PCI, the recommendation is to factor in mostly the risk of bleeding as well as thrombosis, and consider if the risk of bleeding is low, triple therapy, or alternatively dual therapy with, I would recommend clopidogrel rather than aspirin. If the ASBLED score, if the bleeding score is high, then probably the weight of the evidence is not in favor necessarily of triple therapy, but more for dual therapy with, again, I would recommend an oral anticoagulant and clopidogrel. We might argue that dabigatran enables you to use a lower dose regimen, which has been shown to have the same stroke risk of warfarin, but a lower bleeding risk. So you might argue that using clopidogrel and dabigatran low dose would be the safest choice. The duration, though, of these regimens, despite these being very recent guidelines, may be discussed. 4 weeks in some cases, 6 months in others, maybe even in between 3 months, in other cases 12 months, even though 12 months of triple therapy is probably a little bit too much in most cases, unless you have very old generation drug-eluting stents. And recommendations are again clear-cut in patients with a firm indication for oral anticoagulants, for instance, atrial fibrillation, which has VAS score at least 2, recent venous thromboembolism, left V thrombus, or mechanical valve prosthesis, oral anticoagulation is recommended in addition to alveolated therapy. Please don't forget that if you have a prosthesis, the novel oral anticoagulants are not indicated, and you should still stick to warfarin. And these are more peri-procedural recommendations to have a watchful approach before PCI and before angiography is performed. Consider additional parenteral anticoagulation if INR is less than 2.5, and consider also that these patients probably need to be cast by the radial axis, avoiding femoral axis as much as possible. And you can also consider in specific patients, and if the operator is reasonably experienced, not withholding oral anticoagulation either. Following coronary stenting, DPT, including new agents, should be considered as an alternative to triple therapy. This is very interesting. We have no data on the APT with prasugrel or ticagrelor or in patients with atrial fibrillation, but it is conceivable that the stroke risk is going to be reduced in comparison to dual therapy with aspirin and clopidogrel. And so, if you will, using ticagrelor or prasugrel on top of aspirin will probably give you some benefits which are not exactly as much as those of anticoagulation plus antiplatelet therapy, but probably are better than the simple combination of aspirin and clopidogrel. If the bleeding risk is low, triple therapy should be considered. Again, it's your approach, it's your decision making. If the bleeding risk is high, then dual therapy is probably better, or triple therapy for a very, very short term, for instance, 1 month. Should be considered as an alternative to triple therapy in patients with high bleeding risk and low risk of stent thrombosis, despite the fact that this is not been shown by recent trials such as LEADERS-3. And the guidelines do not encourage the triple therapy with prasugrel or ticagrelor. Indeed, I think this is probably better used very, very, very selectively, because this is a typical scenario, at least as the Italian practice is concerned. If the patient has a major bleeding, then you probably be facing hard time justifying the decision to have triple therapy with warfarin or an oral anticoagulant and ticagrelor. Radial access is recommended, and this is very interesting. You should use a new generation drug-eluting stent rather than BMS if you have a bleeding risk, if you have an indication to warfarin. from a very technical perspective, this is a very big novelty, and it's a paradigm shifting approach also for the guidelines. At least 1 year of dual therapy is probably best, even if this also can be, debated in keeping with the recent data from new generation drug-eluting stent trials. The problem also of bleeding while on or anticoagulants has been faced by the guidelines, and you have recommendations mostly based on expert opinion or consensus on the way to best manage these patients with bleeding. For instance, in patients with bleeding during warfarin therapy, you can reverse the anticoagulation effects, but this might be somewhat risky in some patients. So you can consider this, but it's not necessarily recommended. And an important preamble is that, for instance, looking back at the cases, we have seen that bleeding may be important for the patient, but might still be minor. So what we want to really recognize and address or prevent is major bleeding, which I would define as fatal bleeding, of course, intracranial bleeding, bleeding requiring transfusion, or bleeding requiring an invasive procedure. Any other type of bleeding, unfortunately, I don't think it necessarily qualifies. So for instance, bruises or some bleeding while shaving, it's not necessarily a type of bleeding that needs us to reconsider our strategy. Again, the scores are very important. I think we are a little bit behind today with the scores. So now we have, for atrial fibrillation, a number of scores, I think at least 10 scores only for thrombosis risk, so for stroke. The most commonly used to date is the SHA-MC score. So basically it's a score of stroke risk, of thrombotic risk. As you know, age plays a very important role, prior stroke plays a very important role. The idea is that if you are elderly, if you have had a prior stroke, or you have had a combination of any of the other risk factors, then your risk score increases and you face a substantial risk of thrombosis. And this risk is reduced by using anticoagulation. So as you can see, these are very interesting data from Sweden. You can see how by increasing SHA-MC score, you have an increased risk of ischemic stroke in yellow, very remarkable increase. You have a significant increase also in unspecified stroke. You have some increase in the risk of pulmonary embolism, and you also an increase in risk of TIA. Of course, we consider these patients at low risk of stroke and these patients high risk of stroke. By looking at the graph, I think you need to recognize that we can't simply say this patient has a SHA-MC score above 1, because if the patient has a 2 score or a 5 score or a 9 score, it makes a big difference. So you need to think that every score has a different impact on the risk of thrombosis. The Hasbled score, again, it's a score this time on bleeding, so the risks that the patient is facing of bleeding while on our anticoagulants. These data are very important because for the first time in this type of patients, being treated with the PCI and stents, we have a score which is telling you exactly like a compass where to go. So should you go right or left? And the score is very helpful because the DEP trial is a very interesting, very large trial, showed that you can reduce MACE with the prolonged APT, but you might increase the risk of death. So you might save patients from infarction, but you might kill patients. And how come this? We have actually tried to reason on this in a meta-analysis we published in The Lancet, I think in March. The key point is that the DAP trial was so large and included so heterogeneous patient population that it could identify different signals of effect in different patients. And I think that the investigators have really come a long way by highlighting which patients should receive what. So we're not talking about atrial fibrillation again, we're not talking about oral anticoagulants, but I think this is a comprehensive score which tells you this patient is at risk of bleeding rather than adverse events in terms of thrombosis, or the patient is not that at risk of bleeding, or the ischemic risk offsets the bleeding risk. And in this case, you can see the age plays a key factor, and all the other risk factors increase the risk of thrombosis. And the key point, you have a very nice distribution of scores. So in this very large trial, a number of patients had the DAP score of 1 or lower, so with the tendency towards more bleeding, or a score of 2 or higher, so a tendency of more ischemic events. And you can see from the slides very interestingly how if you take patients who have a tendency to bleed, and if you continue DPT more than 12 months, you actually kill patients. You have an increase in the risk of mortality. You of course have more bleedings. The net adverse events, so MACE plus bleeding, is not in favor, despite some reduction in thrombotic events. So these patients don't prolong the APT. You're gonna kill them, you're gonna cause bleedings, and this is something that we need to think about also for anticoagulants. But if the DAPT score is higher than 1, so there is a tendency towards more ischemic events rather than bleeding events, then you don't kill anybody, you're not saving lives, but the key point, you don't have any risk of death. You have a tiny increase of bleedings, but you have huge reductions in ischemic events. So we need a score in the future that will tell you where to go being aggressive or not aggressive in atrial fibrillation and oral anticoagulants in patients undergoing PCI. Thank you.